Hey everybody, welcome to another episode of Clinic Gym Radio. I am your host, Dr. Josh Satterlee, and I'm lucky enough to be joined today by Anthony Vittese. Anthony, how are you?
What's going on, Josh? Happy to help you out here with these podcasts. My first one.
Yeah, listen to that silky smooth, deep voice, man. This ain't nighttime radio, brother. You can pick it up a little bit.
I've been told I have a face for radio, so.
Hey, can you give everybody an idea of who you are, what you do, so that they know why I have you on this podcast?
Sure can. So started out as a traditional orthopedic outpatient physical therapist. Been in the clinic for a lot of years. Started out as an aide in high school back in the mid-'90s. I'm not going to date myself. Was originally in one of the Pat Croce-owned clinics in the Philadelphia area, so kind of got my start there. And from there, was in the corporate world for a long time. A little nonlinear guy, so school was always challenging for me. Once I got out, I realized that there needed to be a different way. Kind of came full circle through a good friend, not a plug here, but Perform Better. And she said, hey, these two guys, Gray and Lee, are really up to something. I took my FMS class in, let's call it 2009, and then was hooked from there, started talking about SFMA, jumped on board, and now I've kind of been an instructor for the better part of probably about 7+ years at this point.
Yeah.
So now
I met you in Washington Duke Hotel, baby, over in where was that?
Raleigh,
North Carolina.
Durham.
Yeah, which was, how long ago was that? 6 years?
2012-ish.
Dang, that's crazy to think about. Yeah, so you worked the clinical orthopedic model. Who was your friend at Perform Better, by the way?
Erin McGarr.
Really? The Erin?
Erin and I grew up together in Washington Township, New Jersey.
The best investment they ever made, right? Even though Mike Boyle told Chris not to hire her. I heard that at a keynote. It ended up being a great decision. She's amazing.
Erin's good people, man. Known each other since we were kids.
Yeah. Very cool. So you're an instructor. You've worked in the physical therapy world of the classic orthopedic, like post-surgical joint replacement, post-ACL, et cetera, et cetera, et cetera. When did you realize that, like, your belief system was, I want to get into sports here, but when did you realize your belief system and your knowledge was, like, diametrically opposed to what you were seeing or what was being recommended to in the clinic?
2003, when I first got out and started working.
So immediately, your first job, you go, this is stupid.
I didn't think it was stupid. I just didn't understand it. You know, if you take 10 shoulder labral repairs and you go through the protocol, 6 of those people might be fine. 4 of those people struggle. And then you do what you do to repair.
And only 2 out of the 6 are like return to play, right? Like are not complaining all the time.
Yeah, let's even go even different than that. So let's go those 4 you struggle with. And then you're going, well, I'm doing what the protocol says to do for a labrum.
Right.
And what's going on? And then we defaulted to, well, this guy's surgeon was better than someone else's.
Yeah.
And, you know, it's kind of funny, the last couple of years I've been talking a lot about that too. And that's just what I went on because that's what you're taught in the traditional PT model. You just see it and it comes down the track. I had read Athletic Body and Balance in college as a strength coach and I didn't get it, but there was something to it. And I've gone through the knee class and the ankle class and it didn't make sense how I was still treating a body part and how some people get better and some wouldn't. I thought I was a good enough coach. You know, again, we can use ACL example, 10 ACLs, 6 get better right off the bat, but the other 4, you know, I tell them to keep their knee over their toe, and it didn't work. Well, I might have been missing something. It might have been a hip. It might have been an ankle. And that the model opened that up to me when I got to SFMA. It took me some time, but I got there.
Nice. And when did you get so disgusted with it you knew you had to change something? 2 years into clinic?
No, it was pretty immediate that we needed to.
Here's the issue I would just picture you went on. I know that you're a driven dude. You're good at what you do.
Thank you.
So in the world of I'm not giving you a compliment. I'm just stating facts.
I was just trying to be nice. Yeah. So
we'll jab at each other here once in a while. No, but seriously, so you're good at what you do. You're driven. You want to get people better. And in the world of PT, what I've learned from an outside perspective of being a total stereotypical chiro versus PT idea here, that means you become clinic director, right?
I did that.
Yeah.
I needed that on the resume.
Yeah. Now, don't let anybody, not to get a big head, sometimes clinic director is you're the only clinician at a place or you got a staff of 2 or something like that, right? But you become clinic director because you're getting great results. And they're like, oh, yeah, we want you to teach everybody how to get those results until those results interfere with the billing system, right? Like
100%.
Yeah, 4 visits is great, except for the fact that we need you to get more visits because we got to have an average of 8, right?
Or it's billing has to be higher with less visits.
Right, which mathematically is tough to do when you're controlled by the insurance companies and what they're willing to pay, right?
Yes, sir.
All right, so they want you to see 1 visit with a very happy customer and get paid $10,000.
That would be ideal.
Yeah. Okay. Well, it's simple. How hard could that be?
Yeah. Well,
and get the referral, right?
Sure.
Yeah. So you became a clinic director, and so in one sense, like, hey, from the managerial side or from your pathway of this business or this office you're working in, you're going up, right? But on the other side, the deeper you get into it, I'm gonna guess the more frustrating it became. We're getting further and further and further off base here.
I had an interesting path to that. I had been offered a managerial position in the Select Medical organization very early on because I'd been in the organization for a long time.
That's a lot. Like, is that a large provider? PT
Select
on
Medical
the
is,
East Coast?
I believe, the largest in the United States.
Okay.
Yep. I was under the NovaCare system. Great system. Not a bad word about it. For me,
The pain management group is called the Novocaine system, by the way.
yeah, that's not. I wish. I would have needed them. So the way it worked was I saw how some of the clinics ran, and being the only PT or one of 2, and I kind of didn't want to do that. I wanted to learn. Finally, we had an opportunity to subcontract from a very large orthopedic group in the Philadelphia area. Basically, hospital special surge, Stebbins Hawkins. The area was the Rothman Institute. So we're lucky enough to join up with them.
So Premier Surgical Group.
Yeah, and that was the only way I could get in front of some of the doctors to really learn and kind of say, hey, I'm not just Anthony calling from such and such a clinic, and I can get some response and learn more about what they were doing in surgery. So I ended up taking that gig there, and they opened a satellite clinic, which I ended up managing for a couple of years there.
And was this like on site? Basically, you were
in the same room, same
in-house
hallway,
PT
in-house
for them?
Absolutely.
Yeah.
So we ran that as a subcontract model.
Okay, but that was on paper, right? To the patients, you were directly after the surgery.
Kind of, yeah. We were in the same building.
Okay.
Everything was billed through their system.
Okay.
They just had a subcontract that we ran their PT.
So I know you enough to. Who was the first doctor you told was wrong? To his face.
I didn't use the word wrong. I posed it a lot more diplomatically.
How did I know this?
So needless to say, some of the physicians
tell us how that
there,
went. Come on, you're a good storyteller. So how'd this go?
So
what's the patient setup? Like, did surgery on the wrong side? Or you don't think that the surgery they did was
no,
the right
just
one?
a couple of them where a young guy came in and said, hey, my big thing was I came to the doctor. I can't do push-ups, and I get some pain when I do push-ups. And, okay, great. And you're talking to the young guy, and I just saw him kind of holding on the walls and kind of fidgety. And as I'm just going through a subjective, he had one pupil that was completely dilated, and the other one was pinholed. Started doing some standard testing on him, and it didn't flush out. Kind of went and chatted with the doc.
Give me one second. Like, how far after his initial visit was this visit you're seeing with the pupils?
No, it was that initial visit with me.
Okay. All right. Cool.
And I was like, hey, you know what? Kind of let's go through some stuff, and it wasn't fishing out. And I walked back to the physician in the office, who's awesome. And I was like, hey, did you take a look at these things? And this doesn't make sense. You send them back in. Send them right back over. And these guys are seeing, 30, 50 people a day. And,
right. 3 minutes apiece. Like.
Correct. So he comes back and he comes back and grabs me. He's like, hey, great call. We're going to get him blood work. Here he had extreme vitamin B deficiency.
No kidding.
And was having all this neurological stuff dealing with the vitamin B that some days when it was higher, he was able to be active.
Sure.
Other days he wasn't.
Yeah, that's the, what is it? Stroke versus vitamin B deficiency.
Yeah,
that's the neurological where you juice them with vitamin B, and if they get better, great.
Yeah.
And if they don't, shit, they had a stroke.
Correct, kind of. So, so I've had a couple of those, which is, we'll leave them at that. And that was kind of a good start to have that discussion. But
now, how about orthopedically? I mean, because there's a lot of times you saw surgeries that might not have been justified in your model.
Let's talk about the simple knee scope. It's very easily performed. It looks good on MRI. There's a degenerative meniscus, and it's floating. And they go in and scope it, and they have the same pain. And there's just
I've never met, and I'm not saying it doesn't work. I've never met a patient that had that procedure, that had their knee scoped for meniscus degeneration, that then said, I'm better. I've not met that person.
So the problems with that is a lot of times it's pes anserinus tendinitis, or the ankle was the problem, and then when they go down steps, they still grinded the knee.
Yeah.
And now you just remove the little cushion that they had.
Yeah.
So
and it feels good for 4 to 6 weeks because they're resting and
juiced up with lidocaine and whatever else is in there, and you basically have that discussion with the physician a couple of weeks later, and when you fix the part that you thought was the problem and their pain gets better, it's kind of a moment where the physician goes, I respect that, and then you start to get all their people.
Right.
So it was very easily do what you do. So it was an earned procedure, but we had a lot of good physicians there that were very open from the PT end. So
now while that's going on, you're out on the road, you're teaching, you're doing some contract work for some professional organizations, you're doing some poking your head in here and there in a lot of places. And so at some point you kind of have to draw a line in the sand, right?
Yes, sir.
And well, let's go back. So you're a PT and you're getting into these professional organizations. Since most of my listeners are chiropractors, what's the role of a PT in a professional sports organization?
It's all different. To kind of circle back a little bit, basically, I had the opportunity, my role expanded here with the functional movement systems, and I had to get out of clinic, 8 to 5. The wraparound weeks and all were beating me up, and my role changed. So I had the opportunity to do that. I had to take it. When you go into these organizations, it doesn't matter which sport, it's all different. We just got done off air talking a little bit about how some sports are very much more archaic than others.
Yeah.
And the traditional PT model was someone's hurt, go do some soft tissue work. Or
what do you think the most archaic sport is, in your opinion?
I'm going to have to, I hate to, and I love the sport, I hate to, but it's baseball.
The only one I've seen that's more archaic than that, I think, a friend of mine, my best friend, coaches swimming.
I went 4 major. I'm sorry. I went 4 major sports, but yeah.
Yeah, I mean, swimming is like our sprinters swim 10,000 meters today, and our long distance people swim 12,000 meters today. And it's like, you're training for a 50-meter race off blocks. Like, you spent no time teaching these kids how to jump off the block. Like that's how you win all the races. Just teach them how to actually jump. And I think, work on their broad jump. You might actually win more races with no swim training.
Yeah, I mean, I went 4 major, but there's a lot of stuff out there that could definitely use some help in the fitness and medical world.
Or, just common freaking sense, man.
That's a long shot nowadays.
All right. So going back, the professional organization, you started poking in, and what roles were you seeing PTs play there?
So a lot of times we'd see PT was just if you're hurt, go see the PT.
Right. So you had to be injured before you ever
most of
got
the time.
Assessment. Okay.
Most of the time, that was it. A lot of the teams didn't even have PTs. If you look at some of the models now, the NFL is traditionally an ATC, athletic trainers, dominant. Baseball is the same way. You saw some of the baseball teams have some dual certifieds, but PT was always kind of the go to get your soft tissue work done or go get your shoulder work done and then come back and the athletic trainers will get you game ready.
Right.
So that was, and it still is in certain places seen that way. Nowadays,
there's that big old handoff to handoff to handoff to handoff and hope that everybody communicated.
Yeah, there's that's still an issue.
Hope is not a strategy, right?
Yeah, exactly.
Yeah. So you saw all those models, and then where are you seeing it the best? Like, what's the best version of that?
So the best version of that is when the medical staff is on the same page with the training staff, and they're all involved in the physical, the performance testing, the data collection, and then the team meeting of, hey, I just saw Josh. Josh's ankle's an issue from the surgery 3 years ago that he had with other teams.
Yeah.
Hey, well, Josh's vertical leap is down.
Yeah.
that might be directly proportionate to the ankle. So let's come up with a plan to fix Josh's ankle, and then I can get him back to you to increase his vertical to build the power. And then he can, steal bases, that type of thing.
Nice.
That's the best. It's few and far between.
Yeah. It's interesting when you go to, it's always interesting, like in workplaces or like, in the military, they use language differently, like I had a Air Force colonel told me, if you tell the Marine Corps to secure a building, they're going to send in 2 platoons of guys and post a guard at every door. If you tell the Air Force to secure a building, they're going to have an airman go online to find out who the owner of record is and negotiate a lease.
It's very, very
and I see that in medicine, but
that.
but like at these professional organizations, sometimes like you can tell by the way they're wording it. Like if it's head medical doctor, head physical therapist, head strength coach, if they're if they're building silos by licensure, from what I've seen, that doesn't seem to work well. But what does seem to work is if you have a director of performance as a larger umbrella and things fall under that, that seems to be a more progressive setup, although sometimes they just use that language and don't actually do that. But
more often than not.
Yeah, but they at least are using progressive language, I guess.
The concept is there.
Yeah.
That also is being used, I would use the word infrequently at best.
Are you seeing physical therapists be the director of performance, though, or is that usually a different licensure? Because it used to be the lead dog was the medical doctor, and then pretty soon everybody's realizing the medical doctor is like the bazooka, right? Like it has a very distinct purpose. Pull it out when you need it, but until then, do everything you can to avoid it.
I think the position that would most likely tie all of those things together that could speak a little bit strength and conditioning, it could speak a little bit athletic training, return to play, that could speak a little bit head team physician is what a physical therapist or a chiropractor would be, something like that.
Yeah. I don't know of any chiros that are doing the performance director.
I don't either. But the idea is that I think the schooling lends a little bit more holistically.
Right.
And
assess the system,
be able to
hands-on care right now, and if not, refer. Like
to be able to effectively communicate that through the group.
Yeah.
And the bigger thing to, the upstairs front office guys.
Yeah. Nice. So in your work, so for folks listening, if they're trying to build a great team, even if, let's not say professional, because those, like everybody has this perception, by the way, that professional care is great. Professional strength training is great. Professional medical care is great. Anthony's laughing so hard he had to move the mic. So
no, I'm not.
But where and then like a trickle down like that college and but if somebody listening is like, hey, I want to build the best performance team because I really want to see, like, let's say that a young or a wise Anthony goes home to his alma mater high school and wants to help them win a national championship in basketball or at least a state championship in basketball, right? How would you put together that team from what you've seen that works?
That's multifactorial. That starts a lot of times with that starts a lot of times with the coaching staff.
Yeah.
If the coaching staff's not on board, problematic off the
top.
All right,
let's say that the dude that your brother is the head coach.
Sounds good. So the team's going to consist of medical, performance. Let's even use alternative, something to the nature of a sports psychologist or an alternative, and a traditional medical as in a physician. And all of those people have to be aligned in the same, I don't want to use same goal because the goal is to win the championship that's already set. The goal of that would be to manage each player the most effectively so that they do what they need to do, and that would be play basketball.
Okay.
Specifically, I'd have to go into, a little bit deeper and start looking into, well, is somebody going to cover the nutrition part? Is somebody going to cover the sleep part? Is somebody going to consider the school part?
It was a high school team, so when you're at Taco Bell, here's what to order, right? Ask for extra lettuce on your taco.
Cheesy gordita crunch. I haven't had one in years, but I would kill you for one right now. They came out with a bigger one with meat in it, too.
Dude, and they're like, we wrapped this whole thing in a tortilla, filled it with cheese, threw it in the deep fryer, and then we deep fried your straw just so you get some delicious
I could
fried
give you
goodness
my,
with every drink.
We're going off the rails, but I'd give you my Taco Bell order right now, and I haven't had it in probably 3 years. But
Dude. Oh, I can't believe that's what has fueled, at least my hometown, that's what fueled more high school sports performances than any other fuel source was Taco Bell, man.
100%.
Yeah.
Ours was Hula Hands. It was not far from school.
The hell is that?
So, one of those chain like TGI Friday places.
Oh, nice.
Yeah.
So going back to the ultimate performance team, so you have all that, and so really the broad strokes are, it's not what the licenses are, it's communication. And
System.
then would you set a system, and would you set up assessments like on the front end?
Absolutely. And I think everyone being on the same system tends to lead to less left on the table.
Yeah. This is the funny part, because I'm sure everybody listening goes, oh yeah, once you're injured, I do an assessment, right? And this cracks me up. I mean, all the haters about the FMS. People are like, oh yeah, it doesn't do this, it doesn't do that. It's wrong, it's the wrong and all this. If you're going to sit there and say, what's the assessment to run on a high school football team, to just say, are there any issues that are low-lying because the kid's been on summer break for the last 4 months, he hasn't played since last season, any issues I need to worry about, or is this kid ready to go? What the hell are you going to do?
I get you, man.
Yeah. I mean, like,
I'll call it bias, because we're part of the system.
yeah.
But you talk to Gray, you talk to Lee, and I talk to those guys frequently, and Kyle and Greg, and something better comes out. Gray said it on
Email
air.
us.
Gray said it on air. He's like, I'm in.
Yeah.
I was listening to, I forget where Lee did this talk, and I use it all the time in the courses now. All the stuff that's getting bastardized, and I'm not here to defend the system. This is what came from one of the founders. Lee said, I can sum up in one sentence, what the FMS is. And he said, that is to tell us what not to train, what pattern not to train that day. Mm-hmm. That's it.
Right.
It took on a life of its own, but that's it, coming from one of the co-founders from the ground level, day one.
Which, by the way, is like the essence of evidence-based care in some way, because basically my interpretation of evidence-based care is do everything that you think works until we get research that says don't do that for that, right? Don't do the cranking internal rotation mobilization of the shoulder because it ends up resulting in poor performance. Okay, now you have a reason not to do something, but until that point, should do everything that works. I would say that evidence-based care is eliminating more than it's saying to incorporate.
And the end of every study is we always need more information on that study.
Exactly.
Right?
Yeah.
So, yeah, those are, circling back to the question on that, the system becomes the driver, really. Mm-hmm. It's, can we find a way to effectively see who is the most at risk and put them in a bucket? Can we see, do they need to be managed medically, or do they need to be managed differently, strength conditioning-wise?
Right.
And, again, just filtering out, and what's the goal? We need the kids to be available.
Yeah.
And if they're physically capable.
I mean, when I was in high school, I played in a small Catholic high school, and we had 29 dudes one season. 29.
That's
our whole team.
That's the whole team going to
two-way
football,
that's not
basically.
That's not a full special teams event, man. Everybody's on special teams.
Yeah.
It's it was different, but we're pretty close dudes now, even now today. But yeah, I think people, we used the system and helped out a local golf team, which would be probably the least thought of team, and right away, there's 3 kids with back pain. There's, because we ran FMSs, then we obviously did TPI, but nobody ever reports pain. They don't self-report pain, but you realize, damn, if we want to win the state championship, we got to have all these 3 kids playing. Because the way golf is, you play 5, keep 4 scores. Well, if you have a team of 8, which I think is what they're allowed to have, and 2 of them are off, that leaves us 6. So that's only 1 kid who's either
odds.
Yeah,
simple odds.
Yeah, man. It's why would you do that to yourself? So I just think put that team together, run the whole system on the whatever scale you can, whether it's high school or college or D2, NAI, whatever. You'll be amazed at what fleshes out at the end. We ran it with the firefighters in our area and got a nice little, $20,000 contract to work with them. We ran the system. It's. I don't know why people hate on it, man.
I think the other part of it is it takes the blame off the table for whether it's a strength and conditioning problem versus a medical staff problem, and it takes the finger pointing off.
Or Anthony's opinion of this kid.
Absolutely.
You know?
It gives you some objectivity to where, going back to this pro sports thing, everyone sees the injury report and says, oh, superstar is hurt. And then you start to blame the training staff.
Right.
A lot of times the training staff didn't know that person was in pain because they didn't tell them.
Right.
Or, they didn't realize, hey, we're burning this guy out in the gym. And, so the training staff's going, well, that's a soft tissue injury that they got from lifting weights.
Yeah.
So now it's strength and conditioning fault. Or they didn't sleep enough, so our sleep consultant was wrong. Yeah. Or so it takes a lot of that off the table, and it gives you that information to really work as a group and say, all right, these guys may or may not be more likely to be hurt. Let's manage them differently than someone else who's appropriately moving, has appropriate control, whose strength is good and endurance is good. They're just got to be handled differently. I think when you have that information, it's priceless because you can still have that kid play and they can get through a season. And if you think about what most of the teams do is, 182 games of baseball, you manage guys.
Yeah.
You make your change in the off season, which is, we just joked about that in off air as well. When you have 6 weeks in off season, but that's when you make your changes. But until then, it's management. But if you can make that change and manage that situation better as a group, you got a guy that plays all year.
Clinic Gym Radio is now sponsored by the CSA, the Chiropractic Success Academy. We don't let PTs in, sorry, buddy. So
I'm okay with
but the Chiropractic Success Academy was put together by Dr. Bobby Mabey and Dr. Kevin Christie. All about the 4 parts of a successful chiropractic business: your mindset, your business skills, your ability to produce great content, and of course your clinical skills. So being a great diagnostician, being great at mobilizing joints, helping people get out of pain, thinking about those things, along with the business or the person that you are, having a positive mindset, looking at growth. Maybe that's managing employees, manage your home relationships, whatever. That's all incorporated in the CSA. If you're interested, go to membership.csacircle.com. Again, membership.csacircle.com, or hit up Kevin Christie or Bobby Mabey on Facebook or Facebook Messenger and ask them how you can get into their program, because they're doing great things. It's not just business lessons and videos. It's also ongoing content. It's assessment calls with those guys. It's a supportive Facebook group. So they're doing great things there. You too can do great things by joining the CSA Circle, the Chiropractic Success Academy, at membership.csacircle.com. All right, we'll get back to Anthony and his love of crappy care right now.
Stop, I didn't say that.
Yeah, well, it's what... cool. So, final thoughts here, Anthony, because I know you got to go. You have a very important meeting about very important things within the world of sports. The highest level teams you've seen, the highest level, one thing that we talked about was, they'll bring in these consultants like yourself, run a bunch of assessments, and then 6 months later, nothing's changed, right?
Correct.
All right. So if you were to step back and tell a young chiropractor here who wants to work in the world of professional sports, wants to get their name out there, young PT, something like that. If they have the skill set to assess, they get the opportunity to go in and work with players. Assess players, whether it's a college or anything. What would be the one thing that you've learned? Hey, do it this way to have some success. What's the next step after the assessment? It's easy to get the door open and go, hey, assess our players, but nothing changes.
I think it's a several-fold answer. One would be...
We don't have time for that. Wrap it up.
I hear you. One would be to make sure that you pose the findings to the staff respectfully, so you're not just coming in there and
shoving it down their
throat. The other thing would be to actually treat them and then retest and show the change. And I think those are the two most powerful ways to really
that's a big deal.
get that
schedule your
across.
Second assessment while you schedule your first, right? A lot of people do that, but it's like, dude, you just took down the scoreboard if you don't do that.
Don't continually give me problems. Give me solutions.
Yeah. All right. And then so set up a conversation for the results, not just
Correct.
Not just mail them a paper.
Whether that be the team trainer, the physician, or whoever, say, hey, we took a look at this a little differently. So-and-so said they never had this type of thing done. During the findings, I found out that, the hip that hasn't been hurt and doesn't move, we did some work there, and then we retested these tests, and their scores went up to be within the normal range for that athlete in their sport and their age group. And I think, having some of the software with the red, yellow, green light system of where these people fall, you don't have to argue with, hey, but Tommy's the best pitcher in 13-year-old Babe Ruth league. But he also moves the worst, and he's probably going to blow his UCL. Right. But
he's going to be the most unknown 14-year-old pitcher.
Correct. It's going to take that off. It takes that off the table, and I think the argument of who's the best player versus who's the best player going to be in 3 years, or who's going to have duration is going to be. I think that takes over from there.
All right. Well, Anthony's got to hop on a private plane and fly to a professional organization.
Super private.
Yeah.
We can't even talk. We shouldn't even be talking about it. It's so private.
So we're going to have to wrap this up right here. He's getting pulled away. But Anthony, thank you very much for the tips. Anybody that wants to reach out to you, how can they find you? Because you are not on social media.
I'm not on social media. I'm a word of mouth guy.
You're like the freaking A-team. Remember that? If you can find them, they can help you.
VIPsysteminfo@gmail.com.
Are you serious?
That's it, man.
That's not Prestige Worldwide?
It's close to it.
Say that.
V as in Vincent, IP, like very important person type thing. Systeminfo@gmail.com.
VIPsysteminfo@gmail.com.
That's it, man. Right now, it's cloak and dagger, man. I'm Bane.
Man, you were like a high-paid mercenary. All right.
I'm more of a mercenary, but I need the high pay part to come.
Well, on behalf of Anthony Vittese, this is Dr. Josh Satterlee saying go out there, maximize your license, and live the life you dream of.
Thanks a lot, Josh.
Thank you.
Thanks for listening to Clinic Gym Radio. If you're ready to double your profit without working longer hours, please visit clinicgymhybrid.com and find out how easy it is to get started on your path to freedom. That's clinicgymhybrid.com.